actually states something bigger than that, which is called this is called the double gulp. And there is now the mega cup that is bigger than that. And not only that, it's refill free of charge. So if you eat in, you dine in, you know, all of us, everybody likes free food. So we go and not take only the biggest cup, but we refill it and refill it and refill it. And that does contribute. And of course, beside that, to recognize a problem, or to treat a problem, you have first to recognize it. You have to recognize that I am obese to go and solve it. And all bariatric surgeons, I don't know, probably most, my practice is like that. When I ask my patients, obesity is at 3 grades, 1, 2, 3, and she's actually beyond 3, most of them think that they are in the middle. They don't really think that they are really obese. So she's blaming the towel that's too heavy rather than her being obese. And that's more or less is a fact. And once you recognize that you are obese, then you have to have the determination to solve it. Not only to recognize it and then go home, watch TV, eat popcorn, and use the remote for everything. And just like this guy, he's saying, oh, the doctor said, you have to start it gradually. I just passed by the gym today. So it's important that you recognize the problem and work hard to, let's skip that. This is distribution of the fat. This is important. Obesity is a complex disease. It's not something, you have to tell your patients clear from the beginning. It's not something that is magically treated by surgery or tablets or injections or exercise. It's a complex thing. It needs a lot of understanding, a lot of involvement by the patient and the doctor, and a lot of commitment. And that's actually a combination of those 3 factors. It's environmental, behavioral, and genetic. Genetics is actually the least important. It's mostly the environmental rather than even the behavioral, because I'll come to that. Obesity as a disease is no longer a lifestyle issue as a disease, and I'll talk about that shortly. So who is considered overweight? In the 50s, insurance companies needed to define who is obese because that was reflected on the fees that you have to pay for your insurance because of the, comorbidities of obesity. And they came with the things that we used to know, the charts of the height against the weight, and then you have a graph, and then you just plot it, and you know where you are on that graph, whether you're obese or not. But like late in last century, we came with the BMI, the body mass index. And the body mass index, to cut it short, again, for the sake of the time, it is definitely not the most accurate measure of obesity, but it's the only one that we have. So we have to do with it. And BMI is the body mass index, and this is how do we calculate the body mass index. Body mass index is your weight, the weight in kilogram twice divided. Your height in meters doubled by the weight. So, like if you're 100 kilograms and you're 1.6 meters, then 1.6 by 1.6 is something. You divide 100 on that outcome, your BMI, right? And if you're working in Britain, then pounds are a pound has 2.56 kilogram, and an inch has 2.2. So one of the grades of obesity. Before you go to obesity, what's the normal BMI? Or what's the standard ideal BMI? That's 18.5 to 25. Below 18.5 is famine, and above 25, sorry. How did I go there? I'm sorry for that. And 26 to 29.9, this is where you can manipulate lifestyle issues. This is overweight. It's not a disease. 30 BMI is a disease. You can't really tell your patient, you have to change your food habits and you have to exercise. He will never lose weight enough or long enough, because all of us can lose, those who are habits, we can lose up to 40 kilograms in 2 months. The question is, how long can we maintain it? So a patient above 30, you will have to help him with something other than food and exercise. It's not a lifestyle modification. It was obesity 30 and above was registered by the American Medical Association, AMA, arguably the most credible medical body in the world. It was registered in their index as a disease 2013. And that's why American companies started paying for bariatric surgeries, because now it became a disease and not lifestyle issue. Then if you're 35 to 35.9, that's morbid obesity. That's the second level of obesity. And it is, of course, more serious and more complicated. And then there is the severe obesity or super obesity or whatever you call it. This is the highest degree of obesity, which is 40 BMI. There are people who say 35 plus a comorbidity is fourth degree. Actually, it's not. That's used mostly for insurance. So it's 30, 35, and 40. And somebody will say, okay, what about 65? They are still above 40. They are still severe obesity. There's a subgroup that you might hear about, which is called super obesity. And by that, we mean the 50 BMI and above, but that's a secondary issue. It's mostly 30, 35, and 40. Before I go to that. So it's just quickly, it's now generally agreed that if you are 30 to 35, then you won't need surgery. And that's a very ethical issue. I mean, in the UK, in the States, in any civilized country, including the Emirates, you will be penalized if you do against that. You'll be suspended, probably expelled from the country, because it's illegal and unethical. So 30 to 34.9, they will never undergo surgery unless they have a serious comorbidity. I had patients whom I performed Roux-en-Y gastric bypass with 31 BMI, but they had bilateral ankle prosthesis with implants, and they had reports saying that if they had 10 kilograms more, those will break. Or you have a patient with insulin resistance. I had a patient who was on, probably you will not believe that, who was on 900 units of insulin a day. And his sugar never went below 350. And his endocrinologist said, you either perform surgery on him or he might die soon. His BMI was 33. But that's the exception, and that's approved internationally. Other than that, you should not operate on those patients. Well, if you're 35 to 39, then here any other couple of morbidities, even if they are mild diabetes on tablets and mild hyperlipidemia, polycystic ovary syndrome, sleep apnea, any combination of those is an indication for surgery with 35 plus. And 40 and above is on its own is an indication for surgery. You can operate on those patients. We're not talking about more details. Again, you know that. And this is the projection of how obesity is increasing in prevalence over the coming 20 years. And you can see there's a big, it's going here steadily until the 80s, and then suddenly it's starting going very sharply. And if you look at the projections in 10 years from now, 8 years from now in the US, then 44% of the population will be obese or morbidly obese. How do we manage obesity? It's a multidisciplinary approach. And again, this is all, I'm not going into much details because that's for the bariatric surgeons, but whatever I'm telling you here, it's not done because the surgeon wants it this way or likes it this way, or the patient, likes it to be this way or pays for it to be this way. It's not about money. It's not about who likes what and who dislikes what. It's about protocols and guidelines. And bariatric surgeons know there are consensus all over the world every 2 years, 3 years, and we come up with guidelines and protocols that change from every few years depending on the data we get. And it's based on results from hundreds of thousands of procedures and outcomes. And they are all statistically analyzed to the highest levels to be adopted as guidelines. So I might not probably talk about it because of time limitations, but this is all governed by regulations. So there's the medical treatment, there are the non-gut offending procedures, there are the endoscopic procedures, and there are the surgical procedures. I'm going to touch them all quickly. The non-gut offending, we have 3 modalities. We'll talk about it. Endoscopic also, we have 3 modalities. Medical treatment, very briefly, it's really, really not that effective unless you are grade 1, which is 30 to 34. And even those, it's not very much effective on its own. Diet and whatever. Exercise is important. Again, it's not that effective on its own. Behavior modification is good. It's not that effective on its own above 30. They are all very effective. I mean, exercise and behavior modification below 30 when you're overweight. Drugs, those are the three major drugs. The third one is not in use anymore. The stimulants, the appetite suppressants, those are the GLP-1 agonists and inhibitors. And probably you know them by trade names: Victoza, Saxenda, the Ozempic, and Trulicity. Those are the drugs that are very popular, and they are good when you use them as an additional measure. Antidepressants, I think the most famous now is Contrave. Is the only FDA-approved tablet that was derived from an antidepressant that reduces appetite. It was modified, biochemically modified to decrease the suppressant, and those that reduce fat absorption are not much in use. Actually, they are withdrawn from the market in the Emirates. I think disadvantages are very long. It's mostly because it's not consistent, it's not long-lasting, it's not very much liked by the patients, and generally speaking, it's not really very successful. Indications: overweight, which is 26 to 29.9, and very low end of BMI, first degree, 31, 32, without any comorbidity. Non-gut offending. Unfortunately, the video will not work here. The V-block, vagal blocking therapy, is actually a machine that's composed of four parts. It has two cables, it has a generator, it has a charger, and it has a pulse something. I'm sorry, because I've never used it. It's not very much popular now in most of the world. It's actually an electric generator that, just like the pacemaker, is implanted under the skin, and you have two electrodes that you can laparoscopically, through tiny incisions, attach to the anterior and posterior vagus. Laparoscopy takes like 10 minutes. And then you can program that with a device that you put it just over the skin, like this wireless charging pod. And of course, it has a charger. And you can generate pulse that stimulates the vagal nerves to reduce the function of the stomach and the evacuation of the stomach. It's a very complex thing. It's not very popular for low-end BMIs. You know, the trends come and go. It's not really something that's worth doing nowadays. The Intergastric balloons, and here by order, this is the first and probably the only till now FDA-approved balloon, the Orbera balloon. And apart from this balloon, all the other balloons stay in the stomach for 6 months or less. So the Orbera is introduced with an endoscope and is removed the endoscope in 6 months. You fill it with 500 cc normal saline. You put 2 cc of methylene blue, just in case it's ruptured. Then you will know, because the patient's urine will become brilliant green. And then came the O balloon, the capsule, which make it easier. The O balloon actually is 250 cc. You swallow it, the patient swallow it in the X-ray department without any medications. You take a picture and it's there. It's 250, and it's the only balloon that's filled with air. So the mechanism is totally different, and one balloon is generally not enough. You will have to have two at least, very unusually 3, and you space them week by week. I used to I'm not using it anymore. I'll tell you why. I used to put 2, and a week in between. We'll talk about the indications later. So it made it easier because there's no sedation, no endoscopy, blah, blah, blah. The cost was a bit more because I now have 2 balloons or 3 balloons, but you had to remove them with the endoscope. So that was another glitch. On both those, you cannot really manipulate the volume of the balloon, which is, in my opinion, not a big deal, but commercially, they make a big fuss of it. Oh, sorry. And then this is the SPATS balloon. That's the only adjustable intergastric balloon. You can see this hook. You can go with the scope, pull it out, inject more, and it will go in. And the advantage of this balloon is that it can stay to 1 year in the stomach. Others, 6 months or less, but I never used it because I've seen the effect of balloons. The orbera that stayed for 8 months, patient didn't come back, and we removed them, and the stomach was severely, severely inflamed. I'm not a fan of that, but it's in the market. Some doctors use it. I don't. And this is the state-of-the-art balloon, the last balloon, which is called the programmable balloon, the intelligent capsule, كبسولة ذكية لا أحد لا هي ذكية ولا هي مبرمجة. All what's there is this is a capsule. It's a balloon that made into a capsule, and this you swallow it in the X-ray department, and it will disintegrate the cover, and you'll get a balloon that you will inflate through this tube, 500 cc also, and then the genuity in it is there. It's a patent that nobody could duplicate till now. When you pull the tube out, there's a very thin flap valve that closes the balloon, and that's it. It stays in. And on the other side, there's this thing that you see here. That's another valve that gets dissolved on its own in 4 months, plus minus 1 week, and then the balloon will go out with stool. So no injections, no endoscopy, no sedation, nothing. And it is fantastic. This is the one that I currently, for the past 2 years, I use routinely. It's great. And of course, it's less expensive because you are not using endoscopy, you're not giving sedations, you're not. And the results of the balloons I have one balloon more. This balloon I was trained on in the States. I never used it, and it's very seldomly used anywhere in the world. It's called the Reshape Balloon. And each one of those balloons is 450 cc. So that's almost 1 kilogram. And it was mostly introduced in the States for huge BMIs, like 72, and the risk of operating on them was very high. So they put this for like 3-4 months, and they downgrade them by 4 or 5 points, and then they operate on them. The issue is when they started using it, patients spent most of their lives in the ER because of the pain and the vomiting and everything. So it never came to the Emirates. I will never use it even if it came. I saw the patients there, and it's really a pain in the neck, to say the least. Oh, 3 minutes? Okay, then endoscopic endo barrier, very quickly, it's a sheath that you introduce through the endoscope. It has hooks. You extend it into the duodenum. There's a small ball that drag it. It's like 1.8 meters, and then it will disintegrate, and the hooks will attach to the pylorus. So the bile will not go mixed with the food. It will go around the sleeve and get mixed with the food after like 2 meters down the stream, which is more or less a bypass, which is not surgical. It was very popular. Eventually, started causing liver abscesses for no reason. I don't know. Nobody could know why. Then it was withdrawn from the market. But 2 years ago, it was back. It's a good thing. That's a primary obesity suturing endoscopy. It's an endoscope that you do plication from the inside to the stomach, but you don't suture it. You put the suture and you put 2 plastic plugs on 2 sides, and you bring them together to reduce the size of the stomach, trying to mimic the sleeve, but it's not really that effective like the endoscopic sleeve gastroplasty, which is the trend now. I think it will fail in a couple of years. I mean, it will be abandoned in 4 years. I think so, because so far the best results they come up with in the best centers in the States, a Jordanian American friend called Barham Abudaya is leading that. And their best results is 18 to 20% of total body loss. Forget about that. Very quickly, Akram. Surgical treatment, forget about that. I'm sorry. So the types of surgery are mostly malabsorptive. Before that, types of surgery are purely restrictive, and those are the horizontal gastroplasty, the vertical banded, and those are all abandoned now. Okay, we don't use them anymore. And of course, the band. The band, there's a lot of discussion that it's not restrictive; it's actually obstructive. It doesn't restrict the side of the stomach. It obstructs it from food from going on. So we don't call it really restrictive anymore. This is only for historic reason, probably. Banned, we used to do 18 to 20% of our patients balanced 2009. Now we're doing less than 1% because, I mean, I don't want to waste your time. And then we have, we have the Risticlip Operations, which is mostly sleeve gastrectomy. And this is how we do sleeve gastrectomy, so many things about it, but it's not really, now we are convinced it's not really because of its restrictive effect that it's giving those great outcomes. It's actually because of the hormonal changes that accompany it, mostly with ghrelin, GLP-1, GLP-2, and the YYPP. So glycation, for those who haven't heard about it, this is the endoscopic glycation is doing this from within. That is doing it from without. بالعربي احنا نقول نخبنها المعدة. We just glycate it and we narrow it. That was very popular 8 years ago. Started losing popularity 6 years ago. It's very much limited in use or not really in any credible center in the world nowadays because of so many things. Mostly restrictive. That's unlike people know. Roux-en-Y gastric bypass is not a malabsorptive procedure. Roux-en-Y gastric bypass. 2 minutes. I'm sorry. Roux-en-Y gastric bypass is not, it is the gold standard, by the way, but against which we measure the outcomes of all other bariatric procedures. But unlike most people believe, this is not a malabsorptive procedure. This is a mildly malabsorptive procedure. It's mostly restricted because what we leave of the stomach is 25 cc. Ping pong, and that's it. And then we do the diversion. Diversion is not huge, but the patients will have to stay on vitamins for the rest of their lives. And the mostly malabsorptive, which is much stronger than the Roux-en-Y gastric bypass, is the one anastomotic gastric bypass, not the mini gastric bypass. We don't call it mini gastric bypass anymore because people started to think because when they have mini, it's smaller, less effective. It's not. Actually, we started calling it mini because with the Roux-en-Y gastric bypass, we had 2 diversions. With the OEGB, you have only 1 diversion, so you are 50% less. So we called it mini. Patients started thinking that, oh, this is a small procedure, let's have it. It's not small. It is more absorptive, stronger than the bypass. There are certain indications for the bypass still. So we changed the name. Now it's called one anastomotic gastric bypass. Now, if you send a paper to any credible magazine, journal, and you write mini bypass, they will reject it because this name is not known anymore. The last thing is, just to mention it, are the malabsorptive procedures, and they constitute less than 2%, I think, even in the UK, of the practice, which are the long limb Roux-en-Y and the biliopancreatic bypass and duodenal switch. Thank you very much. I'm sorry.
We leave all the questions till the end of the session, please. عندك شيء قلتي تخلي على تريد يصور. اي ويب سايت صارت عندي 12 دقيقة. Thank you very much for Professor Safwan, and we are sorry for the logistic problems happens for your presentation. The second, may I invite Professor Dr. Akram Abed Hassan, and I think he is known for all of you. He's a consultant, general surgeon, and bariatric surgeon, to present his talk about perioperative preparation and pre-rehabilitation of abdominal reconstruction patients, and the stage for you, Dr. Akram. دكتور صوت معك.
أذني كبيرة. Okay, yeah, that's okay. Yeah. Again, thank you very much. The reason I'm giving this presentation because I consider that the abdominal wall reconstruction is one of the most important topics that we can face as general surgeon or plastic surgeons. As you know, the incisional hernia may occur in 20 to 30% after laparotomies, as elective laparotomies, while the percent is much more in cases of emergency. So many surgeons will, many reasons for the problem, including the type of surgery, experience of the surgeon, way of suturing materials, and lastly, the SSI, which we have in these cases. Once it happens, then all the efforts should be taken by specialized surgeons with proper preoperative assessment and preparation. That's the reason now that nowadays considered as a specialty by itself. Abdominal wall reconstruction nowadays is a specialty by itself as any other specialty in surgery. It's shared activity between the plastic and the general surgeon. Plastic surgeon. So once we have a case of abdominal wall problems or hernias, then there are steps after presentation. The first thing to do is the preoperative workup of this case. So what to do? The first thing is to do the CT scan. CT scan should be done in all cases of abdominal wall hernias, big hernias. CT scan will give us the mapping of the abdomen, and then you can assess the comorbidity risk factors, do consultation whether or not they need bariatric surgery. From that, then you will put your surgical plan. Surgical concept, timing, whether you use Potex or not, and the prehab. The prehab is considered the most important step in preparation of these patients, which we'll discuss individually later. So after that, you will have a definite surgical plan, result of a prehabilitation, weight loss, result of the Potex, then you go to surgery. In order to prevent the complication, you should optimize your operative care. Every detail matters. Right indication for the right patient, right technology, and as I said, the prehabilitation. I'll go very fast because we don't have time to give everything. So, right indication, the first thing is you should know the right hernial classification. What is the type of the hernia, which is really important to put in mind once you see your patient. As another classification, which is HBW classification, is not validated but useful. The H is for the size of the, that's how you should consider these cases. From that right indication of for the right patient, abdominal CT is the most important thing. The problem is with the CT that we have now in our city here, that they just send you a plain CT would give you the size of the hernia. The size of the hernia, the surgeon can assess it by himself. All the CTs in this case should be done CT with contrast. Why CT with contrast? In order to visualize all the muscular wall of the abdomen. You should know all the muscles, where is the defect, if there is any detachment, as it happens here, this one. Sometimes you can't see because just you see the hernia itself and you concentrate on the defect, while there's a detachment because of previous surgery, for example, and you assess the domain of the patient. You assess the pelvis. All these things are gathered together in order to put a final assessment whether you are going to put down the contents of hernia or not. From the CT scan, you can see the previous mesh, especially in recurrent hernias. And as you can see here, that the mesh is thickening there. As you can see here, there's interstitial hernias. This is all you can tell by the CT scan. From the CT scan, you can tell the adhesion of the bowel to the abdominal wall. And that will differ in the consenting of the patient, because definitely you are going to tell the patient that he might have a bowel injury during this repair. So all these steps is known as you can tell by, what is that? That's the area they use it. They use it either in 3 spaces or 5 spaces. They inject the cortex in between outside just superficial external oblique, in between the external and internal, and over the transverse muscle. The timing of that is very important. Some people, they start that 4 to 6 weeks, and the most important timing is during the last week before the surgery. It gives sometimes 50% chance of the 50% decrease in the size of the abdomen of the defect of the hernia, which means a lot for the surgeon in order to manipulate during surgery. 50% is not something simple. So again, now what type of mesh you use? You should have an idea what type of mesh you use. According to the staging that you have, in grade 1, any mesh can be used, but you use retromuscular. There is now no chance for the only use of repair in these cases. So it's a any type of mesh. In type 2, where there is no SSI, so it's macro-synthetic mesh, biosynthetic mesh. While in type 3, you can use the biosynthetic mesh or Ovitex. While in type 4, the only chance you have to use is the Ovitex. The Ovitex is a reinforced type of mesh. It's very strong, and it is resistant against the infection. I said that I'm going to speak about the prehab and the abdominal. This is very important, really, the prehab, how to prepare your patient. There is smoking, diabetes, nutrition, infection control, obesity. I'll go very fast for this. So it is a vicious cycle. What is a prehab? Why the prehab is important? Prehab is like a marriage. Prehab is like a marriage. Small problems might lead to divorce, might create a very big problems. So you can see here that the hernia repair, surgical site infection. Once they have SSI, then they are going to be readmitted, hernia recurrence, reoperation, surgical site, and you go on this cycle. So we should be very careful in preparation of these cases. So we have a pre-operative strategies, intraoperative strategies, and post-operative strategies. I'm not going to go in all three, all of these things. So pre-operative strategies, these are the things important, and there is a level 1 based evidence about this. You can read about the reconstruction, evidence-based strategies for the rehab of the abdominal wall reconstructive patient. It is very important. And we have the intraoperative, the skin preparation, antibiotic glucose control, and we have the postoperative and these things that you know. We concentrate on the nutrition. And nutrition is very important. Sometimes it's a very important point in the impaired wound healing. We have all seen this defects in our cases, and we think that is infection. It's not only infection. It is the malnutrition. It's exactly like you are going to Baghdad with a car, putting a half tank of petrol. I want to reach Baghdad. You can't. You should have a full tank in order to reach Baghdad. So protein malnutrition, particularly the deficiencies in arginine, glutamine, and methionine associated with compromised healing, and that's again level 1 evidence. It prolongs the inflammation, disruption of matrix deposition, decreased deposition of collagen in the skin. This all leads to this picture that we all see. So albumin should be above the 3.5, perialbumin more than 15. No chance to speak a lot. This is a very good graph that can show predicting the high risk of surgery, and you can all see that the level 3.5, the morbidity mortality decrease here. And it goes to most of our surgeries, but in abdominal reconstruction is very evident. So you always put in your mind the 3.5 level of albumin. That's the reason you should send your patients before doing the surgery. Again, the diabetes is very important in prehab of these cases. Diabetes, we all know that diabetes affects the medium and the small vessels. What we don't know is that diabetes affects the collagen. The glycosylated collagen is more in these cases, and that's why what we face. And this collagen will be resistant to degradation. If the collagen is not degraded, then we don't have a proper collagen for healing process. And that's very important in these cases. Importance of, you can see from this graph, once the blood sugar is over 200, then the mortality recurrence of the hernia is more. And that goes not only for diabetic patients, also for non-diabetic patients. When the MRCA, we don't consider MRCA in our country. In our cases, MRCA is a well-known fact all over the world. The only country in the world which have a low incidence of MRCA is Iceland. And MRCA by itself might increase 40, if you control the MRCA, you will have 44% reduction in postoperative wound. It's very simple, mupirocin, chlorhexidine. And our patients, you can tell them to have shower, to clean themselves, to clean the axilla in between the legs, to clean the nostrils just a week before surgery. You might increase or reduce a reduction of infection and the recurrence of the hernia. Obesity, and Dr. Safwan have mentioned that obesity is very important because by 2030 we'll have disaster in obesity. It is a significant factor for seroma dehiscence, fistula, infection, hernia recurrence. So it is risk of recurrence is increased with as BMI is increased, and you see the journals that prove that. This is a graph that gives you a very good picture about it. So recurrence by the BMI, you can see when the BMI is below 30, the recurrence is only 7%. While when it goes to more than 50, then 50% of recurrence is there. So there is no point to operate on patient who has a high BMI. You should have a solution, either diet control or even you go to bariatric surgery. Don't touch a high BMI patient in cases of abdominal reconstruction because the recurrence is very high. And that's what we do see in our society here. Again, it's not only the BMI, the fat itself, the muscular people. And again, they are more prone. So this is a morphomic measurement of predicted SSI. It's not a BMI, it's subcutaneous, total body circumference. Smoking, we don't care for smoking. Smoking is very important. Increase the odds for wound complication, odds for wound dehiscence, odds for superficial wound infection. They said it's 1 cigarette per day might increase the incidence of SSI by 40%. So how can you imagine, Dr. Haidar, how can you imagine people taking more than a pack? So 1 cigarette increases the risk by 40%. So it's very important in these cases that, this picture I think كلنا شايفيها in the smoker patient. So you always should tell your patient to stop smoking. In elective cases, it should be within 6 weeks' time, they should stop the smoking. And recommendations for the smoker, postoperative healing complication occurs significantly after an often smoker, more complication in former smokers to those who never smoked before. Again, I want to go very fast because I know the time is going on. Interoperative strategies are very important in these cases. You see this theater, a lot of people, as in our theater that we have here. So the source of wound contamination in these is direct contact, transfer from equipment, airborne dispersal from the staff, self-contamination, physical migration from patient own skin and flora. As a source of infection, patient own skin is the direct source of contamination, only 2%. Surprising, isn't it? It's just 2%. And usually nowadays, because we learned before that we should do immediate shaving on patient on the table. Nowadays, it should be done outside, clipping rather than shaving. Might decrease the cause of the incidence of the SSI. 98% are related to airborne particles, 30% to settling, and 70% of settling on instruments and surgeons. لذلك احنا بهيك كيسات لازم عندنا dirty tray, عندنا clean tray. When you use the mesh, we shouldn't use the dirty tray. We should only use the clean one and non-touch technique as the orthopedic people they use. It's very important. All these factors might decrease the incidence of SSI. And recommended antibiotics prophylaxis is very important thing. The cefazole intravenous 1 gram إذا كان أقل من 80 gram. يعني the weight of the patient is very important in assessing the dose. وين دكتور نور سمعتيها لا؟ ف 1 gram less than 80 kilogram. Alternative to that is the clindamycin or vancomycin. The timing again is very important. we used before, we learned before that was seconds before the before the surgery we give our antibiotics. Nowadays it's not like that. 30 minutes before the incision, vancomycin 1 hour before the incision. Redose, we need a redose in cases of takes more than 3 to 5 hours during surgery. While عملياتنا تطول أكثر من 3 to 5 hours. If the wound is open and if there is a blood loss more than 1,500 cc. And this is a proof for that. It's just 2 hours to before surgery. Post-operative strategies. It's randomized trials, multicentric trials on a lot of patients. It proved that mobilization of the patient might decrease the incidence of the complications. Impaired wound healing, hypothermia and pain. This is a very important problem that we can face. Hypothermia. وصالاتنا باردة. يطلع بريدنا برا هم بارد. We don't care for the patient. We care for ourselves. احنا بالثياتر نريد نبرد نفسنا ما نهتم للمريض. ما عندنا blankets خلي عليه. Hypothermia itself, it might lead to vasoconstriction. The same effect of diabetes. So we should look for that. So hypothermia induced vasoconstriction, painful stimuli. البين عندنا احنا who cares for pain. هي المريض يعيط ورا هذا. بس انت you should cover the patient from pain-wise after surgery. Therefore, adequate pain control can improve cutaneous perfusion. All these factors combined together might decrease our complication. Message to take home, you should always remember to have a CT scan for all our patients. It is really a complex surgery. Share ideas, take time. Don't rush. إذا يجيك البيشنت take your time. مو شرط تخلص أسبوع، مو يجي اليوم يسوي باكر. خاطر حضر أسبوعين 3 شهر شهرين خاطر الريزلتس مالتك يصير better. Don't rush. Proper prehab that we have concentrated on. So you should do it, and we should arrange in the future for registration and NDTs. Nowadays, it is a specialty by itself. It's registered, and no case can go to repair for incisional hernia unless it passes through MDT, exactly like a cancer. Thank you very much.
Thank you very much, Dr. Akram, for this nice presentation. May I invite Dr. Faleh Mahsen and his presentation about surgical treatment of diabetes mellitus. Okay. Unfortunately, he is not present. I think, again, we are lucky to follow the time schedule. Professor Safwan Taha, may I invite you to present your second presentation? Yeah, buttressing the sleeves staples line, evidence, dogmatics, and barrier and belief popularization. Professor Safwan, he is a consultant surgeon and consultant bariatric surgeon, and I am proud that he is one of my best teachers in the college.
Thank you very much. Some more director. مرزنا موجودة موجودة هنا موجودة نعم بطيئة جدا. اوكي فتحت هنا. good. Okay. شكرا. Thank you very much, Dr. Jawad. I had the privilege of working with so many special people and surgeons, doctors, physicians, including yourself. Thanks a lot for the nice comments. Well, you've seen that. You've seen this. Right. So the title of my talk is about the buttressing of the staple line, because this is an issue. يمكن أنا relaxed with time فالح ماجة.
Just we compensate the first delay.
Okay, I'll be try as quick as possible. So buttressing the staple line. It's for the non-bariatric surgeons. Actually, the staple line, it's titanium clips that will close the two edges of the stomach or bowel, and then you cut in between them. And it's bare metal on flesh. And there are people, I mean, industry came up with something that reinforces those metal on flesh mechanism with so many things. One of them is there are glues, there are other materials, there are powders, there are buttressing materials. There are synthetic and absorbable materials that will be covering the flesh, and then the staples will be above that. And there's been a lot of controversy about, shall we, of course it added cost and probably 1 minute or two over the time. But there has been a dramatic debate about the significance of using them. Are they really that good, or they are not that good, or are they harmful? And there's so many data about that. And that's why actually I didn't want to speak about only the data. I'll show the data. But why is there a conflict? Why do we really not agree when there is evidence? Logically, we should agree because there's evidence. But there are two terms I'm going to talk about today that mitigate the evidence value, and that's dogmatism and belief polarization. Those are two important factors in any scientific debate. And of course, when it comes to life-saving in medicine, it's even more important. So what's belief polarization? It's also called attitude polarization, also called polarization effect. What is that? It is the phenomenon where disagreement becomes more extreme as the different parties consider the evidence on an issue. So when we talk about one piece of the same piece, not two evidence, and we disagree about that, that's belief polarization, because it is one thing and we have taken two poles, two extremes about it. That's called belief polarization. And it can be personal and it can be group. And a group is even more effective. And a group polarization is where a group of people who are discussing a point to come up with a verdict will eventually, as a group, come with a verdict that's either less aggressive or more aggressive than they would have done it themselves on personal levels. And the best portrait about that is in jury trials, in civil trials. And you know, we don't have that, but those studies are done outside. So they found beyond, or actually with high statistically significant value, that the jury, when they come up with a decision about the punitive damage award, ta'wid, for a patient, as a jury, they generally come with an amount that either significantly less or significantly more than they would have done if they had decided themselves alone. And that's part of the reasons why people debate about clinical evidence, not on personal grounds, on group grounds. They disagree more or less strongly as a group than they disagree if they were individuals. And that's also important. That's one important part. That's one side of why we don't agree about clinical evidence. So what is the other side? The other side is called dogmatism. And dogmatism actually is the tendency to lay down principles as undeniably true without consideration of evidence or opinions of the others. يعجبك ما يعجبك مازن هذا هو الصح. يا أخي على أساس because I said so. Dogmatism. And I don't know, I'm sure that we've come across that not only in medicine, all in our lives. So what is dogmatic? So it's undeniably true evidence of opinion of others. Diagnostic, dogmatic. What's dogmatic? Dogmatic is the expression given to, the term given to expression of personal opinions very strongly or positively as they were facts. This is more even damaging than belief polarization, because if you think back, belief polarization, we were disagreeing about an evidence. There is the evidence. We both agree that there is an evidence, but we don't agree about the interpretation. With dogmatism, it's not about evidence. It is like that because I think it's like that. That's it. But I have no evidence about that. And practicing dogmatism itself entails, it's the same thing actually. It actually, to be more clear, what it means is dogmatism, if you don't agree with me, it means either you are very, very much less intelligent than I am, or you know nothing about the truth. Without evidence, only because I said so. And I think we've seen much more of that. And that's the other face of the coin that contemplates our discussions about evidence, about buttressing. So what about the evidence? Let's see what the evidence say about buttressing. This is you see that all the studies I'm referring to are new, and they are printed in credible journals, and they are coming up with very good numbers. So this study discusses the staple line treatment, bleeding after laparoscopic sleeve gastrectomy. This is important because it comes from the so-called MBSA-QIP, the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, which is very important source of data in the States. And it's actually the cornerstone of the American Society of Metabolic and Bariatric Surgery data. And this study went through the database 2015, and it discussed the patients who had sleeve gastrectomy throughout 2015, retrospectively. And the patients were stratified with staple line treatment groups into no treatment, oversewing, buttressing, and a combination of buttressing and oversewing. And those were compared. The primary endpoint was postoperative bleeding. We're not talking about anything else now, just bleeding, buttressing and bleeding. And multivariable logistic regression analysis was used to compare the postoperative bleeding amongst those four groups. The conclusion was that relative to no treatment, staple line, buttressing, or oversew can decrease the rate of postoperative bleeding by up to 30%, and should be strongly considered by bariatric patients. Evidence. Belief polarization is one thing, dogmatism is one thing, and this evidence, statistical data and numbers. That's for bleeding. There's another study, and published by SWORD, the official journal of the American Society of Metabolic and Bariatric Surgery, and sponsored actually by the American Society of Metabolic and Bariatric Surgery. And this one is even more extensive than that. It also went through the MBSA-QIP data, but over 2 years, 2015 and 2016. And 2 minutes؟ ما راح ألحق مستحيل. أحكيكم إياها برا الباقي. So this data proved that staple line reinforcement is associated with decreased loss of bleeding. Okay? Again, with 2 years now, and for 1 month post-op, evidence. Buttressing, it's not only the linear stapler, but even the circular stapler, end-to-end anastomosis, and not only the bleeding, but look at the conclusion. Now, even the buttressing also decreases the bleeding-related complications, hematoma, narrowing of the anastomosis, infection, difficulty of swallowing, vomit, whatever. So it also decreases that, buttressing. Evidence. Then another study that's, again, they are also all new. This study compares the postoperative nausea and vomiting after sleeve gastrectomy for buttressing and non-buttressing, and the conclusion, I'm running, sorry, because of time. The conclusion is that buttressing or running suture creates more nausea and vomiting and increases duration of symptoms post-op in the first few hours, making recovery longer compared to buttressing, which produces less nausea, vomiting. Evidence. Leak is the same thing. That's one study that proved that, unlike what most people say, proximal lines reinforcement reduced the risk of leak. That's data of almost 2,000 patients that proved it. And again, Michel Garnier, everybody knows him, bariatric surgeons. He's the inventor of sleeve gastrectomy. He did a meta-analysis of all those studies that assessed leak from 2012 to 2016, and he did a regression analysis, and the conclusion was, by an independent Fisher test, not his own analysis, was that significantly lower leak rates occurred in buttressing than non-buttressing. Of course, bariatric surgeons, Akram, he would definitely give you 2 more minutes, because he would have asked me, what are you speaking, why didn't you mention this study? The American Society of Metabolic and Bariatric Surgeons made a big fuss with this study. They made a really big fuss with this study. And this study, again, went through the MBSA QIP data and for 2 years, and they included, look at that, they included almost 200,000 patients and almost 720 centers by 1,643 surgeons. So it was an extensive analysis, and it was the American Society of Metabolic Surgeons, no less. The conclusion was there was higher leak with buttressing, and that made a big noise against everything else. But then, not all what shines is gold. The thing is, one thing that we know, that we taught, that we're taught expertly in community medicine when we were in 4 years, that you have to do your statistics well to come up with real data. And one important thing in controlled randomized trials, CRTs, is you have to minimize the variables. So how can you tell that it was buttressing? Because it was the same surgeon, the same hospital, the same operation, the same theater, the same consumables, the same blah, 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 blah. The only thing what was different was buttressing. So most probably the outcome was because of buttressing. But when you have 720 surgeons, centers, every center has its own way of approaching consumables and managing things. You have 1,620 surgeons. Come on, how can you really come and say that they did the same standard technique and the outcome was caused by buttressing? So after that study was attacked literally by everybody who was not, that actually was more, that's not dogmatism, because they're talking about evidence. That was belief polarization. They changed the conviction about one data into something. All the people who left dogmatism aside and belief polarization and went about evidence proved that this is not really true, because there are so many variables that divides it from its. Oh, this is the levels of evidence. You can read it. So please, this evidence says evolution is true. Well, The Rock says, I didn't say so. I just gave you one piece of thing, and you cannot build a conclusion on it. And the same thing is that when a group really says something, but they have something else in mind only because they have to run with the group and come up with something that everybody agrees upon. I'm very sorry. Thank you very much.
Thank you very much, Dr. Really nice one. May I ask now, Islamis Hamid, Assistant Prof, Family Medicine, please, for a topic of prevalence and determinants of weight misperception among adult females in Basra City. Dr. Lamis.
هذا شلون هذا خلينا نشوف تمام. السادة وسيدات الحضور السلام عليكم. I will present my topic about prevalence and determinants of body weight. I will talk about the prevalence and determinants of body weight misperception among adult females in Basra city. Concerns about weight are common, particularly among females. However, the concepts of normal, underweight, overweight, and obesity are poorly understood by the population. Self-perception of body weights reflects persons' awareness about their actual body weight. Misperception means either over or underestimation of body weight, and persons who misperceive their weights are more likely to engage in extreme or unhealthy behaviors in order to manage their body weights as they perceived. This study aims to measure the prevalence of weight misperception among adult females in Basra and also to show the characteristics that are associated with weight perception among these females. The study is a cross-sectional study conducted on a sample of females who attended 6 randomly primary health care centers in city center of Basra Governorate. Each participant were asked about her socio-demographic characteristics and also other selected characteristics. Weight, height, and body mass index were measured, and the actual body weight status was determined according to body mass index. For perceived body weights, participants were asked about the weight status they expected themselves to be in as they perceived, and they were classified as thin, normal, some fat, and very fat as they perceived. And these are corresponding to thin, normal, overweight, and obese weight statuses respectively. Regarding characteristics of the studied females, they are more frequently young adults below 40s, and they are highly educated housewives with moderate income and mostly married. Only 22% of them reported a positive history of chronic diseases, and slightly more than 60% reported more than usual stress at the last 12 months. Only 8.5% were either smokers or ex-smokers, and about 1/4 of them reported positive family history of obesity among their first-degree relatives. This table shows distribution of the studied females according to their actual body weight status as determined by their body mass indices. Slightly more than half of them had normal body weights, and approximately, and about 46 of them were either overweight or obese, and only 2.4% were underweight. This table shows distribution by actual and perceived body weight statuses. It is evident that 40% of underweight females perceived themselves as normal, and normal weight individuals, about 40% of them perceived themselves as underweight, and about 1/4 of them perceived themselves as over or overweight or obese, and 1/4 of overweight females perceived themselves as normal weight, while approximately half of obese females perceived themselves as overweight. This table summarizes the weight perception. It is evident that about, slightly more than 1/3 of them underestimate their weights, and about 18% overestimate them. Regarding association between the studied characteristics and the accuracy of body weight perception, it is evident that only age showed a significant association, which is highly significant. And it is evident that us being more younger, being more younger female, this is makes them more likely to misperceive their weights. And as age increase, the rate of weight misperception decrease with a slight increment in the age group of 60. It is evident that all other characteristics show no significant association. Many other similar studies in the world show a significant association, but not as highly significant as reported by this study. Conclusion, the overall conclusion of this study is that approximately half of the studied females misperceived their body weights, and females tend to perceive their weights accurately as their ages increase. The highest rate of misconception is reported among obese females who misperceive themselves as overweight, followed by the underweight ones who perceived themselves as normal. Recommendations: a comprehensive intervention educational program should be devised to raise self-awareness about their weight status and in order to prevent obesity and other weight problems. Thank you very much.
شكرا جزيلا دكتورة لميس على restriction to the time schedule. May I invite Dr. Samah Adayib to present his talk about whole pancreatic and islet cell transplantation, min review, and I think it's a multiple endocrine neoplasia, or what's multiple endocrine neoplasia. Dr. Sam, he is a consultant adult endocrinologist. Middle East, North Africa experience.
Yeah. لا المينا مو على شو اسمه مو على المالتيبل اندوكراين نيوبلازيا.
So it's Middle East, North Africa experience.
Yeah. السلام عليكم ورحمة الله وبركاته. I'm Dr. Samah Adayib, adult endocrinologist from the Qatar. This talk is about the whole pancreas and islet cell transplantation. This is a report for the IDF and the Middle East North Africa experience. Shared with me in this, Adel Ghassab and Dr. Hind Al-Iraqi from Morocco. I have nothing to declare for this presentation. First of all, let's start with the islet cell transplantation and pancreatic transplantation. Really, the experience in our locality, nearly none, but it's young, but mature in the MENA region. بالسنة 1966 بالوقت اللي انجلترا أخذت كأس العالم بالزغل وأمريكا كانت ملتهية بحرب فيتنام ومارتن لوثر كينج كان ينادي بالحقوق المدنية، كان عندنا اثنين من أشهر الأطباء بالعالم
اللي هو Lailihi and Kili, who present their first operation regarding pancreatic transplantation. And they document their results to be mainly in the diabetes type 1 patients with or without end-stage renal disease. For this report that we present to the IDF, we provide a mini review for the pancreatic transplantation and islet cell transplantation, and then we describe the current status of these operations in the Middle East and North Africa countries. Our methodology and involve the PubMed and Google Scholar using query terms regarding country names, pancreatic transplantation, islet cell transplantation or transplant in English or French, and human only between the year 2000 and 2002. We came through 150 articles. Only 50 articles were involved in the analysis. What we already know that pancreatic and kidney transplantation are related in patients with type 1 diabetes, advanced CKD. However, the two transplants are not necessarily to be done together because both of them are not vital organs. A kidney transplantation is a well-known option for patients with CKD, whatever the etiology was. American Society of Transplantation, American Diabetes Association recommend that patients with type 1 diabetes recommend the pancreatic transplantation to be done in patients with type 1 diabetes who have undergone or plan to undergo kidney transplantation. It's not recommended in children really, because it's very difficult to do such thing in children because of the side effect profile, immune suppression, and the profile of graft rejection. Really, the surgeons and the physicians are facing many tough decisions. There are 4 modalities of pancreatic transplantation, and they are governed by the availability of the donors. First one is the simultaneous pancreas and kidney transplantation, which is the most common type of pancreatic transplantation, organ from the same diseased donor. They are indicated in patients with type 1 diabetes and ESRD requiring immediate dialysis or within 6 months. الثاني هو pancreatic transplant alone, and as its name implies, it's pancreas only. Okay, but there is a modality which is pancreatic transplantation in uremic patients, but with little or no recommendation yet in these scientific societies. Pancreas after kidney transplant, as its name implies, benefit include decreased waiting time and reduced morbidity and mortality associated with dialysis. And lastly, simultaneous deceased donor pancreas and live donor kidney, and this is less. The challenges, whatever the transplant was, is the immune suppression, transplant rejection, post-operative complication as any operation, and finally the post-transplant lymphoproliferative disorder. Far from pancreatic transplant, we came through the islet cell transplantation, which is more complex really, but it's not surgical, or somewhat not surgical. We are harvesting the islet cell from the deceased pancreas, and by special isolation of these, by very difficult cytometry, to be infused in the portal venous system in the liver with percutaneous catheter. We used only 2% of the endocrine pancreas. The common indication is the type 1 diabetes more than 5 years with negative C-peptide, type 1 diabetes, which is complicated by many episodes of hypoglycemia and hypoglycemia unawareness, cystic fibrosis, related diabetes, and finally, diabetes associated with the chronic pancreatitis or post-pancreatectomy. But the question is, which is very difficult for many scientists, which one is the 2%, which is very difficult. We need to harvest from more than 4 pancreas organs to help one patient. Pancreatic transplant insulin independence rate at 5 years is higher than ICT, 70 إلى versus 25 إلى 50. الاكسبيرينس بالمينا ريجن هي كلش قليلة. من ناحية شنو؟ انه الاشياء العمليات المسجله بالانترناشونال ريجستر ايرودات والجلوبال اوبزرفاتوري اون دول محدده اللي هي ايران، السعوديه، الكويت، الامارات والمغرب. ايران هي الدوله الكبيره، يعني الدوله الاكثر في عمليات الاورجان ترانسبلانتيشن and in general and pancreatic transplantation in specific. الارقام اللي تشوفوها هنا صحيح هي 0.1 بال 2006 وهنا الرقم مال الكويت مال المغرب 1.3، بس هذا هنا بالاورجان ترانسبلانتيشن للي يعرفون الاورجان ترانسبلانتيشن والمشتغلين، الاعداد هاي ما تنفحص، ما تتخلى انه هي عدد العمليات، لا يسمونها per million population، ماشي PMP. وبالتالي احنا اذا نجي للبوبوليشن مال ايران بال 2006 0.1 كان عدد البنكرياتيك ترانسبلانتيشن. السعوديه بال 2004 باديه اول عملياتها كان 0.08. بالحقيقه هنا عمليتين، هنا 6 عمليات. المهم القصد انه البايونير بهذا المجال هم ايران والسعوديه. الكويت بدات متاخر ب 2008 واستمرت الى حد 2017. ورا 2017 توقفوا بسبب البوست اوبراتيف كومبليكيشن وكانت عندهم فد مشكله بالدونيشن. الامارات قريبا جدا الى حد ديسمبر 2020 بدات بكليفلاند كلينيك اول عمليه وكانت ناجحه لسيده مصابه بتايب 1 دايابيتس سي كي دي وكان سيمولتينيوس كدني and pancreatic transplantation. بس شوي خلينا نرجع لورا. هي القصة ما بدت بال 2004 بالنسبة لإيران، بالحقيقة بدت بال 1994 بهذا المستشفى العظيم اللي هو اسمه أبو علي سينا، اللي هو في شيراز، اللي هو بأكبر مركز لزراعة الكبد في العالم. كان موجود دكتور أحمد إيزاد بانا، هو سوى أول عملية للبنكرياتيك ترانسبلانتيشن، بس المريض توفى ورا شهرين من الجرافت ريجكشن. الهيلث اوثوريتيز ان ايران، ليش هذا السكسس صار؟ بصراحة هو ديني على سياسي، وأنا بالبداية قلت I have no political and scientific thing to be declared. Health authorities in Iran struggle until the Iranian parliament legalized organ transplantation from deceased donor and individuals with brain death in بال2000. ماشي بال2000. ورا 2000 صارت هاي البريك ثرو بإيران which was considered a breakthrough in organ transplantation across the country. وطبعا هم استفادوا من هذا الاكت بالليفر ترانسبلانتيشن اكثر من البنكرياتيك ترانسبلانتيشن. السعوديه بالمستشفى الملك فهد تخصصه ومركز الابحاث بدأوا بال 2004 وهم لحد الان عندهم 2 modalities اللي هو simultaneous pancreatic kidney and pancreatic after kidney. بالامارات بهذا المستشفى العظيم اللي هو كليفلاند كلينيك ابو ظبي باليوم 21 ديسمبر 2020 كليفلاند كلينيك ابو ظبي performed the first pancreas transplant for young women in her 20s type 1 diabetes in the setting of simultaneous procedure. الكويت سوت اول عمليه بال 2007 بس توقفت بال 2017 بسبب الشورتج، وبصراحه هم ما عندهم قانون يحكم الدونيشن. بالنسبه للآيلت سيل ترانسبلانتيشن ورا 2012 ايران هي الوحيده اللي اشتغلت بهذا الموضوع. من اقول ايران قصدي بالمينا ريجن، ما دا احكي على تركيا ولا دا احكي على اسرائيل، ماشي؟ بس بالمينا ريجن، ماشي؟ after 2012 after intensified international collaboration، هاي الكلمه خلينا نحط جواها 70 خط، لانه ظلوا 7 سنين سفر امريكا ايران امريكا ايران الى حد ما سووا successful isolation and purification of islet cell from different donors. Shiraz Organ Transplantation Center launched the pioneer ICT program in the MENA اول واحد with first successful transplantation in a patient with type 1 diabetes. وطبعا الاعمال العظيمه دائما وراها نساء ورجال، عاده الاعمال العظيمه وراها نساء. والمراه اللي هي او الاستاذه العظيمه اللي هي نجار أزيربيرا هي كانت اللي هي pioneer in the field. This is the first one who launched ICT in Iran and in the MENA, and she was I need 10 seconds from the deceased pancreas, and this is only the Langerhans cell, islet cell. what we have learned so far, we are lagging. Really, we are lagging. The experience in pancreatic transplant and ICT in the MENA region is young, yet mature. Other countries in the MENA need to start national and regional programs to help many protracted cases of type 1 diabetes in the region. But the question is, when we shall start our own pancreatic transplant and islet cell transplant program? Please, make your move. Thank you.
Thank you very much, Bassam. It's a really informative and new topic that you have raised. May I ask now, please, Dr. Haider Ayad, he's assistant endocrinologist with topic of efficiency and safety of 1.2 milligram per day liraglutide in obese patients with type 2 diabetes from Basra.
شو زين؟ اي هذا وين هذا الكليك هذا صح شيء
للنظارات
ها
النظارات شوي
انزعها ركب هالشيء هالشيء بس البس النظارات اها تمام. Thank you, Mr. Chairman. Good afternoon, everybody. It's quite a pleasure for me and amazing to be here for the second time in the International Medical Conference of the University of Basra College of Medicine. I'm going to talk and discuss this study about the efficacy and safety of relatively the lowest effective dose of liraglutide 1.2 milligram for both obesity management and also at the same time for type 2 diabetes management. Here's my disclosure. And as you know, incretin is a hormone, and principally the GLP-1 receptor. The GLP-1 is an endogenous hormone secreted from the L cells in response to an oral intake glucose. And this will stimulate the beta cell to release the insulin in a glucose-dependent manner and will suppress the alpha cells from releasing the glucagon, reducing the hepatic glucose output, delaying the gastric emptying, and promote satiety. So this hormone plays an important role, importantly, in controlling the glucose homeostasis in the postprandial state. Just telling your brain, don't eat, we have a food, and telling the liver, don't produce more glucose because we have an exogenous glucose. What does the incretin usually do after intake of food? If you compare two patients, one have an increase in the plasma glucose and a similar increase in the plasma glucose after an oral intake of a glucose. We can see a more on higher increase in the insulin release, which is the first phase, insulin release. This is the incretin effect. The problem is that we have two problems. First of all, GLP-1 have very short half-life. That's within a minute will be degraded. And the second, in type 2 diabetes, this incretin effect is reduced and one of the most important pathophysiologies in the type 2 diabetes. So it's an important target for management of type 2 diabetes. So liraglutide is a GLP-1 receptor analog and agonist. It has been approved for treatment for both obesity in a dose of 3 milligram and both for controlling the HbA1c for type 2 diabetes in a dose of 1.2 and 1.8. So we aim to evaluate the efficacy of relatively less expensive dose of 1.2 for all patient locality for both body weight reduction, HbA1c reduction, and its effect on requirement for insulin and sulfonylurea, which are the most powerful glucose-lowering agents. It is a prospective study including 55 patients from two governorates in southern Iraq. I was responsible for the Basra patient, and Dr. Sameh was responsible for the DCAR patients. We include two diabetic patients with obesity and who are willing to start liraglutide. And we exclude patients with any bariatric procedure or any patient who have drugs that may associated with a body weight reduction like SGLT2 inhibitors, orlistat, pregnancy, and according to the FDA label and prescription, we exclude patients who have a history of multiple endocrine neoplasia or family history of such a disease. The intervention is to give 0.6 milligram daily for 1 week and to increase the dose to 1.2 daily and to continue on the same dose for 24 weeks, for 6 months. The patient is have to be seen after 1 week, 4 week, 12, and later on 24 weeks for evaluation for the safety, for side effects, and at the same time for efficacy in terms of body weight reduction and HbA1c reduction. So also at the same time, the modification of the insulin and sulfonyl requirements. The outcome is HbA1c reduction, body weight reduction, safety profile, and the reduction in the insulin and sulfonyl requirement. How we did the down titration of the insulin, we did it on the basis of the targeted basal, fasting blood glucose and postprandial blood glucose. So we aim to reduce the basal insulin dose by the following schedule: 10%, 20%, 40% on the basis of fasting blood glucose, and the basal insulin was stopped for the patient who have a consistent fasting blood glucose less than 90 on a 10-unit basal insulin. And also we target the postprandial and reduce the prandial insulin by 20 or 40% on the basis of the PPG, and with the stoppage of the prandial insulin if there's consistent reduction in the postprandial blood glucose less than 140. Premix have a combination of prandial insulin and intermediate acting insulin, so a similar work was done for patient on premix insulin in a similar way that what we did for basal and prandial insulin. And if there is a consistent postprandial less than 140 on a dose of 115 units of premix, the premix insulin shifted to basal insulin. And also we down titrated sulfonylurea in a similar way by targeting the fasting and the postprandial blood glucose. Here's the general characteristics of our patients. And as you can see here, we included an obese patient, but we have a very high level of obesity for our patient with a high HbA1c, an advanced duration of type 2 diabetes, the mean duration more than 6 years, and 80% of our patients already were on insulin. So it's very difficult to be sure whether the liraglutide will be effective for those patients with advanced type 2 diabetes. Here's the first outcome of the study. And as you can see here on this graph, on the left side, a repeated measure, ANOVA with the Geyser House correction, a post hoc analysis using a bone phenol correction. You can see there's an overall significant reduction in the HbA1c, but what's most important actually is the degree of HbA1c reduction. An average of 18% reduction after 3 months and 23% reduction on the HbA1c after 6 months. And a similar analysis was done for obesity. And we can see here the body weight starts to be reduced significantly. The body weight reduced significantly even after the first month of the study. Yeah. So the significant reduction in the body weight start to be after 4 weeks of the study, and continue to significantly reduce during the period of the study. And these were equivalent to 2.7, 8.4, up to 12% reduction in the body weight in those patients with advanced type 2 diabetes. And since our patients have advanced type 2 diabetes, we try to see the effect of other confounders like age, gender, type 2 diabetes duration, and insulin. And we can see here, independent of these factors by subgroup analysis, we can see there was a significant reduction in both body weight and HbA1c reduction. With another factor, it appeared that patients with advanced type 2 diabetes duration, or those patients who need the persistence of insulin therapy, maybe the liraglutide appeared to be less effective for reduction of the HbA1c, and also at the same time, being older, being female, being patient required more persistent insulin therapy, appeared to be reduce the effect of liraglutide for body weight reduction. Moving to the safety profile, as expected, nausea and vomiting, the commonest side effect with the use of liraglutide. It's quite high in the first week and reduced later on to be negligible. But hypoglycemia appeared to be highest in the first month of the study. And all these hypoglycemic attacks happened in a patient on insulin therapy, and usually happen at the time of the intensification of liraglutide. So the side effects start high and tend to be reduced. Here's the final outcome of the study, and actually this is the most interesting part of this study, because 80% of our patients were on insulin therapy. You can see here the population of patients on sulfonylurea, basal, premixed insulin. What is done after initiation of liraglutide? 9 patients of 17 patients with successfully stopped the sulfonylurea. 7 from 10 patients on basal insulin stopped the basal insulin. 6 successfully stopped the premix, and other 6 shifted to basal. And for those patients with a basal bolus insulin, we successfully stopped the insulin at all in 2 patients, and 8 shifted to basal. So this suggests that liraglutide 1.2 associated with more than 50% reduction in sulfonyl requirement, 34% reduction in the overall insulin requirement, and also reduction, importantly, in the prandial insulin requirement. So in final conclusion, we can say that liraglutide in a lowest dose 1.2, which is more convenient for our patients because the patient need to pay out of the pocket for these medications, appear to be effective and reduce the HbA1c and body weight in a patient with advanced type 2 diabetes with a high HbA1c, even if this effect appear to be less in patients who being older, female, advanced, longer duration of disease, and patients who persistently require the insulin. Another important effect is the reduction in sulfonylurea requirement, reduction in insulin requirement. Side effects is quite high and nearly happen in all patients in the first week of the study. So we have to tell our patient, when you initiate this medication, there are going to be a side effects with the use of liraglutide, and discontinuity to be reduced to 0. And so, thank you. If you are lucky, actually, you will have a good friends, but you'll be more lucky if you have a good friends and good brothers. And each, actually, my good friends and brothers, 2 of them were endocrinologists, and one is gastroenterologist, and the other, actually, I missed him in this conference, is a hematologist. And thank you for your listening.
Thank you very much, Dr. Haider, for your nice presentation. May I invite Dr. Ala Al-Farhan to present his talk about liposuction assisted arm lift, safety and benefit. Dr. Ala, he is lecturer, department حاطينك maxillofacial. He is حاطينك maxillofacial بالبروشور. He is a consultant plastic surgeon at the University of Basra College of Medicine.
خلينا نرجع بس امشي الوادرات بقى يا يتحرك. My teachers, my colleagues, audience, good afternoon. It's my honor. It's the honor of me to stand with my great teachers here. It is very good to put our jobs in the last, because these great lectures by Dr. Safwan and Dr. Akram about the body contouring, we are our job for body contouring. It's my pleasure to share with you my talk about liposuction brachioplasty, liposuction assisted brachioplasty, or it is the arm lift. As you know, there is an increase in the demand for the arm lift after bariatric surgery, after dietary regimes, after decreasing the weights, because many of the patients are concerning mainly about the arm contouring, the shape. Many of them say, please, my doctor, please help me, leave my abdomen. Please help me. I cannot show my arms to my husband in front of my children. I cannot go for the parties. I cannot dress cut. So these are the main problem in many of our people. Body weight, as we said, that's after bariatric surgery. There are many operations for that, and they have very good results after bariatric surgeries. Also by dietary habits, by regimes, by any types of regimes, they have decreased weight. And many others, they have no weight loss, and they want full body contouring for shaping of their arms. This is after the operation, after sleeve operation, after maybe 9 months, 1 year after stabilization of their weights, after I take the informations from the patient or from the surgeons who did the operation, they told us about the time of stabilization of their body weight. This is after dietary regimes. A lot of skin redundancy, a lot of fat still in their hands, in their arms. There is a lot of procedures for the liposuction, for the arm lift. First was popularized by Thorick in 1930. Mainly there are two types, either standard type without liposuction, only excision of that skin and fat and then closure, or nowadays we are using the liposuction for the for the contouring of the arms. There is high functional benefit with the standard type, but there is a relatively high complications rate. In this type, there is lesser complications rate with good contouring and good shaping. Start with the marking in the standing position and the arm in abduction. I start the marking here in the epicondyle region and then a straight line in the intermuscular septum reaching to the axilla. And then I took 2 centimeters above it. The closure will be here. So the patient, when she is sitting, standing like that, and her arms is adducted, there will be no scars obvious in front or lateral or from the back. This is good things about this type. And about the incision posteriorly, it will be according your pinching as a start. Under anesthesia with supine position in arm abducted, and we have to provide antibiotics. It was great lectures from Dr. Safwan, from Dr. Akram about the rehabilitation before the operation. The area was infiltrated with epinephrine. It is the Thompson solution with 1 to 1 million of adrenaline and normal saline. The area infused until it became tense. This is the liposuction method. We use the PAL system, power assisted liposuction. بعض الناس يجوز يشترون هذا الجهاز بعدين. And until it will be without fat. The our aim, no fat or 0 fat in the arm. This is the measurement for the fat. If this is in the 0. So I think there is a video here. This is the power assisted. This is vibrating device to help liposuction of the areas in the body. I don't know why they share my face. No need. Yes. After the liposuction, then we do stapling. But put a surgical staples in this area. I did folding of the skin inside. I did put staples and to assess the tension. And then I use here marking. This is surgical ink. I put it here again after assessment of the tension. This is the picture after liposuction, depression. This is the new marking. Then not the initial marking. This is the new marking after liposuction and after assessment of the tension. Then I have to excise by avulsion. This is, I think, it's not good, but this is what have been left inside the arms. This is only lattice of lymphatics, small blood vessels has been left in the arms. There is no fat. It will be, there is no blood loss. There is maybe 1 drop of a blood of loss during it. I do not need sometimes you to use the cautery, only just for minimum bleeding. Then I use staples again to close it, and then I close it definitely by using the intradermal. I use continuous vehicle 2O and then closure subcuticular 2O proline. This is the lady after, I think she was only dietary habits. After 1 week after the operations, with good, this is still ecchymosis, but she was very satisfied. The left arm, still not removed the suture. Retrospective study to compare the assisted arm lift and the standard method. The complications rate, I divide them ascetic, non-ascetic complications like seroma, infection, hematoma, and paresthesia. There were 0 complications, no seroma, no hematoma, no bleeding, no paresthesia. The standard method, there's cases of seroma, infection, and paresthesia. While the ascetic complications, I have only one case, asymmetry, scar hypertrophy in one case, wide scar in one case, and wound dehiscence. While the other group, they have many complications, ascetic complications. The duration of the surgery, it was about 25 minutes in the group 1, and it was 1 hour and 15 minutes in the group 2, the standard one. I compare some of the complications, the satisfaction rate. Satisfaction in the group 1, I got 4 cases with excellent result, 3 cases with very good, and good in 1 case. While this is the aesthetic result. The functional result, I mean the functional result, how she get good contouring and there is no friction with her body. Many of them, they are concerned about the friction of the arms with the body. They have good arms, they can wear anything, and also aesthetically. While in the non-liposuction group, there were very many cases of bad result, poor result, or good result. Only 3 cases, only 1 case with excellent result. So, the aesthetic result, the good aesthetic result in this liposuction group, this is because I am doing always assessment of the tension of the arm before excision, before doing the marking. If I check the one was not, it was loose, I remove it, I put another 1 staples until it become mildly tense. Then I do excision. Why there is no seroma in these cases? In the usual cases, the standard one, there is a lot of cases of seroma. While in this case, no seroma. This is because of we are leaving the lymphatics and the small blood vessels. These small blood vessels and lymphatics are very important for the absorption of the lymphatics after the operation. So there are no seroma in these cases, and I do not need to put drains. In conclusion, the procedure of brachioplasty associated with post-operative problems, liposuction-assisted brachioplasty has lesser complications. This is thanks to the preservation of the lymphatics and the blood vessels and nerves. There is no paresthesia in such a case. These are some pictures of our patients. This is pre-op with a lot of fat, a lot of skin, with body contouring with very nice result. This is pre-op and post-op. These were with dietary regimes. Also, this is with dietary regimes. These are very small scar, wide scar. We can leave it, or we can do some laser for it to decrease the size of the scar. This lady without dietary regimes, she has body weight. She's didn't change her weight. I think she was obese only. I think about 30 or 26, like that BMI. So she got a good result after that operation. And thank you.
Thank you very much, Vagal. Very good one. I'm sure you will have a lot of questions after this.
Inshallah, thank you.
May I ask you now just to have a photo for the para code that will be available on the screen. In the meantime, I'll ask Dr. Jaber Rahim to be prepared for his topic, reduction of mammoplasty by superior medical pedicle flap with septal perforator-based technique. And Dr. Jaber, he's a consultant surgeon, plastic surgeon. I think you all know him. He's working in مستشفى الصدر التعليمي for the last 20 years. 20 جابر لو أكثر. دكتور جابر صار لك 20 years لو أكثر بالمستشفى. Yes. تصور الدرس. سبيكر بعدين اوكي ما يطلع منه مستحيل.
زين شيل هاي. شكرا جزيلا. I am so happy here to be between my teachers and my colleagues and my student. So I am so happy because I am in the middle. Yes, because you know I am in the middle now between those big head. شكرا البارحة على العزومة دكتور أكرم، حقيقة كانت كلش حلوة. My subject is breast reduction by using superior medial pedicle with septal perforator-based technique. It's wide and large subject, look, but it's very important because it is a new technique that we use it for dealing with this very big, very large breast. The normal appearance of the breast is vital aspect to the female form. Adequate tissue removal must be performed during breast reduction, and nipple necrosis is a potential complication of breast reduction, but this complication can be prevented by surgeon knowledge of the blood supply of breast, particularly the nipple areola complex. So in our study, using combined two main sources of neurovascular supply, which is coming from the skin by superior medial pedicle and coming from the parenchyma by the perforator. Here, this is two types, superior medial pedicle and septal perforating. Two sources of blood supply we're using to maintain the normal blood supply for this long breast. Here, variable blood supply over breast, we have to know the variability of blood supply, what's the most important supply from the internal mammary and lateral thoracic artery. There is many variability of these blood supply. There is the breast contain ligamentous system, and this is very important because it is holding the blood supply to the nipple areola. So we have to maintain this to know the anatomy of this ligament and to preserve it to maintain the blood supply. And the most important, this transverse septum. The marking pre-operatively in a standing position, and we have to maintain this triangle with a medium measurement of 21 centimeter between the two nipple areola and suprasternal notch. So the mid-sternal line and suprasternal notch, zipsternum, inflammatory fold, always we have to put marker for it to find the normal shape and acceptable. This is pre and post-operative measurement. It is 21 centimeter. This is technique of planning, how we plan suprasternal notch, and then they measure the length of the breast. Sorry. This is between two new nipple areola complex, the other side, and finally, we detect the new site of the nipple areola complex. And by this technique, Logier technique, we detect the lateral side of the breast. By this technique, we measure what we resect and what we maintain of the skin, because the skin is very important. And sometimes if there's shortage of the skin, it's very, very, very difficult to replace or from where we take the skin if we resect more skin. So the measurement, very important pre-operatively. Like this patient, we know now what we resect and what we maintain and where's the pedicle and where's the blood supply by this case. This is also after measurement. So in our study performed in Basra, we have 47 patients with age about 38.5 years, with nipple areola distance 37.1, with resected weight about 1.25 gram, and nipple areola complex transfers by mean about 16.1 centimeter. Here, the measurement about 36 on the right side and 37 on the left side. There is variability of the length of the breast in our community. In surgical technique, we avoid the skin and nipple areola avascular necrosis, and we minimize the residual scar and preservation of breast symmetry. And the reduction should include excision of excess breast tissue, reduction of skin envelope, and relocation of the new nipple areola complex. We have to remember always we have this technique, which is superior medial pedicle technique. And we maintain blood supply from the skin and from the parenchyma. Here, detection of the nipple areola complex. And then re-epithelialization of the pedicle. This is after removal of the skin. And here we're starting separation of the pedicle, which is usually long in comparison with other type of surgery. Finally, we spread the breast to the caudal and residual part low down, so we can, after separation, complete separation of the pedicle and the perforator, we do cut as you go. We can resect all tissue low down. This is the perforator by illumination test. We preserve it. And here, this is the tissue what we removed in different cases. Here, start approximation of the tissue, and this is the resected part. According to our classification, all our patients have gigantomastia. We choose those patients with very long breast and very difficult cases, and we concentrate it and we exclude the simple cases. We are dealing with the difficult cases only. This one of the upper patient, about 36 centimeter length, pre and post-operatively, and this is another patient we resect about more than 1 kilo from each side. And this is another patient with 42 centimeter. It's usually large breast with bulky breast, and it is regarded acceptable result by the patient evaluation. Another patient. This is another case. The length 32 on the 9-month post-operatively. Another patient, even apart from there is burn and scar, we preserve the nipple areola. and it is length about 36 centimeter. Another patient with anterior view and lateral view. This is very hugely large and bulky breast. This is another patient with long breast, about 42 centimeter, but this is the thin breast. This is give us better result than this bulky breast because we can relocate the pedicle and we can decreasing the size of the breast. Here, this patient with very long breast, 42 centimeter, and we resect about 1 kilo from each side. This is anterior view of the another patient. And this is so long, it's about 52 centimeter. It is this, it's out of the principle, and we have to put more step anteriorly for dealing with those patients with very long breast. Previously, we do amputation of breast and putting graft. Now we maintain using this flap, and it is viable bilaterally. Another patient. Don't forget our complication. It is sometimes it is more or less than other, but we are more. We have wound dehiscence about 20% of our cases. But we regard this patient with more than 2 centimeter dehiscence, we regard it as wound dehiscence, but most of the patient or all the patient healed by secondary intention. Okay, the other complication is losing of the sensation, but it is less, about 10%, and there is infection because this dehiscence and exposed wound. But, okay. Patient satisfaction about 90% in comparison with other studies in the world. It is about the same. This is another patient. We deducted from step the length of propace, length of the pedicle, and the weight that resected. This patient, by video recording, it's very important. It's better than the picture nowadays. All pictures here, it is from our patient. We are not taking any picture from the others. This is another patient. This is different from the other. It's more bulky breast. Bulky breast more difficult because we cannot decreasing the size more. In conclusion, this technique, superior medial pedicle septal-based technique, is an effective and safe choice for treatment of severe macromastia and gingivitis patient, and we have to obtain the symmetry and shape and good projection. This is our Basra plastic surgery team, and we have a conference on November. We hope to see you there. It's Basra Plast 2020. Thank you.
Thank you very much for this nice presentation. We'll open the discussion now. So we'll give it 10 to 15 minutes. So I think we'll have 5 questions. And at the end of the discussion, the closing of the ceremony will be in this hall. So if I ask you just to stay, please, after the discussion. Who wants to ask questions? We'll start with Dr. Safwan. Any questions for Ustad Safwan? Yes, please, Dr. Laith, Inglaterra. Dr. Safwan, please, if you can, if you come here, please. شوف الأسئلة منهم questions for me or Safwan.
Thank you very much. Thank you very much, Professor Safwan, for the great lecture, and I totally agree with you. The bariatric surgery is a truly multidisciplinary team assessment. My question is, what's your experience with bariatric surgery for non-alcoholic steatohepatitis patients? They don't fit exactly within the comorbidities list, but do you recommend bariatric surgery for those with BMI of 35 who've gotten evidence histologically or biochemically of steatohepatitis?
Thank you very much. This has been an issue that bothered surgeons for a long time. And up to like 6-8 years ago, we didn't have real evidence that, I mean, not really evidence. We don't have data about how safe and how effective is bariatric surgery for necessary liver problems. And not only that, how will it not how will it affect obesity, but how will the surgery affect the condition itself? And over the past 5 years, there's been a growing amount of evidence that it goes positively both ways. It doesn't affect the outcome of bariatric surgery negatively if the patient are prepared well. Bariatric surgeons know obese patients won't go under the knife unless they go through a very long series of assertive assessment by some consultants. And actually, there is now growing evidence that it reverses the liver problems and improves them. So yes, there's a very good place for bariatric surgery here. But that's a very nice question. Thank you.
I think nowadays it's going on.
Yes, it is going on.
They encourage the procedure.
Yes, yes, yeah. Yes, yeah.
That's excellent. I mean, Laith, you live in UK, you practice in UK. You can see that no single case goes for bariatric surgery without passing through the MDT. And that's going for all the specialties. And because of that, there definitely will be discussion, agreement, and then to go ahead for surgery. And building up good experience in the right lane will be through the MDTs.
But that's important. Thank you for raising it, because 5 years ago, we were very skeptical. We didn't know the way forward. But now, we all agree that there's a good place for it.
Yes, Dr.
Thank you for the nice articles. And please, can use multiple clips on the stable line? And can use multiple clips on the stable line? It's routinely used in all the world or not? And use routinely drain or not?
Right. Let me start with the drain. Drain is history, actually. I mean, I don't know. I haven't used the drain. I can't compare myself to big centers. But when I had training in 2005 in Strasbourg, I asked. He said it was so old that I don't remember. When? 2005. I personally haven't used the drain. Current surgical practice is very much against drains because of so many things. I don't want to increase the time, but very, very rarely use the drain. As I showed in the data, I do 1/3 of my practice as revisions, and I have so many cases with double laparotomies before. But drain will only make it worse. If you get a leak, la samahallah, you have so many other signs and symptoms that can tell you. And we are very aggressive with those signs. So forget about the drains. About clips, yes, you can use clips as long as you don't use too much. So you don't obstruct the blood flow to the staple line. So as long as your clips are even 1 centimeter apart, yes, you can do that. But the best way to use those clips is not to go very much oblique on them. So you will not cut a lot of blood supply. So like a 45-degree, yes, you can use them. They're quite safe.
Yes, Doctor. So I totally agree with you about drains. I mean, drains is really history. No one uses drains nowadays. I mean, I haven't seen drains just here in this country. Yeah. And may I ask you, Dr. Safwan, about the buttressing of the age? It's used, I mean, for the complication of sleep, isn't it? So it's either for a leak or for...
You mean buttressing?
Yes.
Yes.
It's either for a leak or for bleeding. A lot of papers say that, I mean, sometimes the leak comes from localized area of ischemia. And buttressing of this age doesn't prevent leak from that side. So some people, they are against that at this point. If there is a bleeding, we are afraid of bleeding, and that, like Su'aila say, you can use clipping all of them, and you can prevent. You can, I mean, in most of our cases, we have just checked that the blood pressure was normal before terminating the surgery, and we check the age. If there's any bleeding, you can't clip it.
Yeah, I mean, but there's a unanimous agreement that it reduces bleeding. That hands down, there's no disagreement about that.
Yeah.
There's a lot of controversy about the leak, and as I shown, pros and again. Actually, because of the growing costs, I'm not using them much now. I used to use them 90% up to 5 years ago, but now it's like them 5%. And I agree totally with you. The two things that I perfected on my technique is that I always keep the stapler closed for 1 minute, not 20 seconds.
Yes, you are right.
1 minute. And over the past 4 years, we've adopted a technique with my anesthetist that when I operate, blood pressure is never below 110.
That's right. Yeah.
And I've noticed in my own hands that when it's 90, 95, and then the patient and recovery in the OR, it starts oozing all over.
Yeah.
When we start doing it 105 to 110, we're rarely putting anything.
Yeah,
And it's
like
very safe.
what you do 1 minute, but I mean nowadays I've read that they have increased that from 1 minute to 2 minutes, which is again is very good. I mean,
Yeah, I mean, don't lose much. It's only 5 minutes or 10 minutes total.
Any questions for? Yes, please. Yes, Dr. Said.
Thank you. I want to ask about the mechanism. How does suppressing reduce
The same guard?
suppressing reduce post-operative nausea and vomiting?
Yes.
What is the mechanism behind?
Yeah, actually, I didn't say this. I said it's not me, the paper. The paper compare the two credible ways of reducing bleeding is buttressing and oversewing.
Yes.
All right. So this study compared oversewing and buttressing, which is better during the outcome. So the buttressing was much better than oversewing and postoperative nausea and bleeding. And the subjective explanation is that this oversewing creates edema, and it will both increase the edema of the step line, and it will reduce the lumen by like 2 millimeters.
So it must be increased the.
So it will make it narrower.
No,
when it's narrower,
the lumen will be less with buttressing.
Yes.
So we expect increasing vomiting because space will become less.
No, there's tube. That's a tube. And when you buttress, it stays like it is. When you oversew, it will become narrower.
Narrow, yes.
So when it's become narrow, you get more nausea and vomiting.
This is the usual.
When with the buttressing, you make it narrower, so you get more nausea and vomiting. So if you want to do something to reduce the bleeding, it's better to do buttressing than oversewing. And the other thing that we didn't mention, there is evidence in the literature that when you wanted to overrun the staple line, it's much better to invaginate than oversew. There have been reported cases of leak from the oversewing the needle. Yes.
Thank you very much.
Thank you. Thank
you. I know we have a lot of questions, but time is very short, and we are about to close the ceremony now. So may I ask Dr. Abdullah Hakim? I think he's coming to do that. Okay. Thank you very much. Thank you very much for all the speakers. It was very nice topics, and I'm sorry that we couldn't keep on the discussion.
شكرا جزيلا للحضور جميعا. أدعو الأستاذ الدكتور علي رحيم هاشم لإلقاء التوصيات والكلوزنج ريماركس للمؤتمر. تفضل.
شكرا أستاذ محسن. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الخلق والمرسلين محمد وعلى آله وصحبه المنتجبين. عقد المؤتمر السابع عشر لكلية طب البصرة للفترة من 19 إلى 21 آيار 2022 في فندق جراند السيف ميلينيوم البصرة برعاية السيد وزير التعليم العالي والبحث العلمي وإشراف السيد رئيس جامعة البصرة. وحضر المؤتمر جمع غفير ومتميز من الأطباء والمختصين من داخل وخارج العراق، ونذكر منهم مشاركات من الولايات المتحدة، المملكة المتحدة، هولندا، السودان، الإمارات العربية المتحدة، الأردن ودول أخرى. وقد تناولت جلسات المؤتمر مواضيع مهمة، منها مراجعة شاملة لخبرة البصرة للتعامل مع جائحة كورونا كوفيد-19، وكذلك النهوض بواقع التعليم الطبي في البصرة، إضافة إلى الأورام وأمراض السمنة وعلاجها جراحيا وأمراض النساء والولادة وغيرها من المواضيع ذات الصلة. وكانت هنالك مساهمة فعالة جدا حول اعتماد كليات الطب وضرورة أن تتم في سقف زمني أقصاه 2024.
تحت غطاء الجمعية العالمية للتعليم الطبي اختيارا WMFE. كما أقيمت هامش المؤتمر ورش عمل تناولت المواضيع جراحة السمنة، التعليم الطبي ومهارات التواصل، الإحصاء الطبي، الرعاية الفائقة والتخدير المناطقي لتدريب الأطباء والمختصين. لقد تميز مؤتمرنا هذا بالاستعمال الأمثل للتكنولوجيا الحديثة في التسجيل واستلام البحوث وتقييمها، والدعوات الموجهة كما أبدت بعض المجلات الرصينة والمصنفة ضمن المستوعبات العالمية لقبول البحوث المنجزة بعد خضوعها للتقييم. ويتحمل الباحث أجور النشر عدا المجلة الطبية لجامعة البصرة والمجلة الجراحية سيكون النشر فيها مجانا. التوصيات العامة: الاتفاق على الاستمرار بهذه النشاطات العلمية بشكل دوري ومنظم، وتعلن إدارة المؤتمر إن مؤتمرها القادم سيكون في آيار 2024 حيث سيتم الاستعداد والتهيئة من الآن. التوصية بتبني أفكار بحثية ريادية نابعة من حاجة المجتمع وتخدم خطط التنمية ودعمها مادياً ومعنوياً. ستقوم إدارة المؤتمر بالحصول على التغذية الراجعة فيدباك، أي الاستفادة من آراء المشاركين ومقترحاتهم. 4. تم على هامش المؤتمر الاتفاق على العديد من مذكرات التفاهم مع كليات عالمية ومع المجلس الطبي البريطاني، الجمعية العالمية لكليات الطب، وأطراف أخرى تكفلت بدعم التعليم الطبي وبرامج التبادل العالمي والثقافي للأساتذة والطلبة. وفي الختام، تشكر الهيئة المشرفة على المؤتمر والجهود الكبيرة التي بذلت لإنجاح المؤتمر، ونخص منها دعم السيد محافظ البصرة الأستاذ المهندس أسعد العيداني المحترم، والسيد رئيس جامعة البصرة الأستاذ الدكتور سعد شاهين حمادي المحترم لمتابعته المستمرة ومشاركاته الفعالة. كما ونشكر جميع من أسهم في إنجاح هذا المؤتمر من جهات وشركات، كما ونثمن الجهود المباركة لجان المؤتمر لما أبدوه من حرص وتفان كبيرين. ندعو الله جلت قدرته أن يبارك أعمالكم وكل عمل صالح يصب في مصلحة العراق وتقدمه. والسلام عليكم ورحمة الله وبركاته.
شكرا استاذ علي. انا صراحه كان المفروض يعني توزع جوائز اليوم، الشهادات تقديريه للاساتذه اللي زارونا من خارج القطر خاصه، بس للاسف انه معظمهم الارينجمنت ما صارت بروبر لان طلعوا غادروا قبل نهايه، فالشهادات راح تكون موجوده للاخوان كلها، ونفس قصر الوقت ايضا ما عندنا وقت. انا ادعو الجميع ان شاء الله نعم. يعني هو المشكله راح تكون يعني موجوده، ما عندنا مشكله، بس راح يكون اكثر من نص نصيح اسماء ما موجود. نعم موجود. اوكي، اذا ندعو الاستاذ الدكتور سعد شاهين تفضل يعني توزيع الشهادات المحاضرين واصحاب ورش العمل. تفضل استاذ.
تيست. الأستاذ الدكتور البروف دكتور محسن السباك المحترم. البروف الأستاذ الدكتور علي رحيم هاشم المحترم. الأستاذ الدكتور عباس الحسيني المحترم. الدكتورة زينة عطوان المحترمة. الدكتورة هنادي جاسم. الدكتورة هنادي عبد الخالق جاسم المحترمة. البروف الدكتور مازن الهواز المحترم. البروف الدكتور مبدر عبد الرحيم محمد سعيد المحترم. موجود دكتور. نعم. الأستاذ الدكتور وسام محمد الغديني المحترم. البروف الأستاذ الدكتور قيس كاظم باقر المحترم. البروف الدكتور محمد شاكر عبد الكريم المحترم. محمود شاكر عبد الكريم عفوا. البروف الدكتور أسعد الياسين المحترم. الدكتورة ميسونة الشريف المحترمة. الدكتور أكرم حمودي المحترم. البروف الدكتور ناثر سعيد حوا المحترم. البروف الدكتور رحيم حالوبة المحترم. البروف الدكتور علي النقاش المحترم. الدكتور أنور الزبيدي المحترم. البروف الدكتور صفوان عبد الرحمن الطاهر المحترم. دكتور عامر سلمان المحترم. موجود. الدكتور زهير عبد الكريم المحترم. المهندس يسار العاشور المحترمة. البروف الدكتور عباس علي منصور المحترم. الأستاذ المساعد الدكتور لميس عزيز حميد المحترمة. البروفيسور الدكتور عبد الأمير عبد الباري عبد الحميد المحترم. الأستاذة المساعدة الدكتور فراس طه منصور المبارك المحترم. الأستاذة المساعدة البروف دكتور سلمان كاظم عجلان المحترم. البروف الدكتور سامر عبد الأمير المحترم. البروف الدكتور إحسان عيدان السيمري المحترم.
لا بعدين حنكمل
الست عفراء فريد المحترمة.
زين وين الثانيات بعد؟
يتفضل الدكتور مقتضى المسافر المحترم لتسليم الشهادة إلى الدكتور سعد شاهين حمادي المحترم. يتفضل الأستاذ الدكتور سعد شاهين المحترم لتسليم الشهادة إلى الدكتور مقتضى المسافر المحترم. دكتور ما أحب أساعدك. الأستاذ البروف دكتور علي رحيم هاشم المحترم. الشهادات الخاصة بالمتحدثين الكرام. الأستاذ الدكتور قيس كاظم باقر المحترم. الأستاذ الدكتور عباس الحسني المحترم. الدكتورة زينة عطوان المحترمة. الدكتور أسعد الياسين المحترم. الدكتور محمود شاكر عبد الكريم المحترم. الدكتور سلمان كاظم عجلان المحترم. الدكتورة لميس عزيز حميد المحترمة. الأستاذ الدكتور ناثر سعيد حوا المحترم. Second time. For the speakers. الأستاذ الدكتور رحيم حالوب المحترم. للتنويه أن الشهادة عن السبيكرز.
موجود. تفضل.
الأستاذ الدكتور أسعد زوما المحترم. الأستاذ الدكتور علي النقاش المحترم. الدكتور حسن علاء فريد المحترم. الدكتور إحسان شاكر محمود المحترم. الدكتورة عايدة عبد الكريم منتظر المحترمة. الدكتور عبد الأمير عبد الباري عبد الحميد المحترم. الأستاذ الدكتور عباس علي منصور المحترم. الدكتور قيس كاظم باقر المحترم. الدكتور علي حسن محمد المحترم. الدكتور آية رباعي المحترمة. الدكتور عدنان سهيل وسمي المحترم. الدكتور أحمد بدر المحترم. الدكتور أحمد الدواس المحترم. الدكتور أحمد جعفر المحترم. الدكتور علا عبد الله فاضل المحترمة. علاء عبد الله فاضل. الدكتور وسام عبد الله المحترم. الدكتور ليث الربيعي المحترم. الدكتورة ميساء عبد الخالق المحترمة. الدكتورة لمى المنصوري المحترمة. ما موجود. الدكتور عدنان عذافة المحترم. الدكتورة جمانة البطاط المحترمة. الدكتور خالد أحمد خالد المحترم. الدكتور خالد ناصر ديوان المحترم. الدكتور ماهر جبار صالح المحترم. الدكتورة استبرق الواسطي المحترمة. الدكتورة ساجدة الربيعي المحترمة. الدكتور ذر البعاج المحترم. الدكتور قتيبة مسلم داود المحترم. الدكتورة رؤى سالم حميد المحترمة. الدكتور مدحت محمد مهدي المحترم. الدكتور منثر الكاظمي. الدكتورة سوسن صالح الهارون. الدكتور إحسان عدنان السيمري. الدكتور لؤي الموسوي. الدكتورة علا حميد. الدكتور رافد العرب. الدكتور ظافر توفيق نعيم. الدكتور عبد السلمان صالح سلطان. الدكتور محمد ثامر التميمي. الدكتورة علاء عبد الحسين داود. دكتور فريد ورد المحترم. دكتور حيدر عبد عون علاوي المحترم. دكتور حيدر الإدريسي المحترم. الدكتور حسنين محمد حسين المحترم. الدكتور حسام جهاد عمران المحترم. الدكتور حسين عمران موسى المحترم. الدكتور إبراهيم حسين المحترم. الدكتور جابر رحيم حميد المحترم. الدكتور عبد الصمد مولانا المحترمة.
الدكتور أحمد كريم الإمارة المحترم. الدكتور علي داود الحلفي المحترم. الدكتور علاء الفرحان المحترم. دكتور باسم المظفر المحترم. الدكتور محمد الرديني المحترم. دكتور محمد توفيق مهدي المحترم. بروفيسور دكتور نائل حسين علي المحترم. دكتور محمد ياس محمد المحترم. دكتور منتظر عبد الكريم عبد الله المحترم. موجود. دكتورة نارين هايزك هاسرات. دكتور نصار طه ياسين المحترم. دكتور سعد عبد الباقي العمر المحترم. موجود. دكتور نصار موجود. دكتورة سوسن عيسى الجابري المحترمة. دكتور عبد الحسين خضير المحترم. دكتور عقيل الصباغ المحترم. دكتورة هنادي عبد القادر جاسم المحترمة. دكتور فاتح الخاقاني المحترم. دكتور فراس شاكر العطار المحترم. دكتور هيثم جواد كاظم المحترم. دكتور إحسان شاكر محمود المحترم. دكتورة سالي أمين المحترمة. دكتورة سرى علي النمل المحترمة.
احمد بس خلينا نختم انت قولها ختام الدكتور علي.
كل الشكر والتقدير إلى الحضور الكرام. كلمة ختام مع الأستاذ الدكتور سعد شاهين حمادي.
السلام عليكم ورحمة الله وبركاته إخواني الأعزاء، ضيوفنا الأجلاء، الجماعة اللي ساهموا ويانا من كل مكان، باسمي واسم عميد كلية الطب دكتور مرتضى، باسم الإخوان اللجنة التحضيرية والعلمية دكتور علي رحيم هاشم، دكتور محسن السباك، كافة الإخوة اللي ساهموا بصراحة بنجاح هذا المؤتمر، نشكركم جزيلا. وكما بدأنا بسم الله الرحمن الرحيم واختتمنا بسم الله الرحمن الرحيم، شكرا جزيلا لحضوركم، نلتقيكم إن شاء الله في المؤتمرات القادمة، وتفضلوا على غدائكم مشكورين.
بس ملاحظة بنقصة السيد رئيس الجامعة، الغداء في مطعم شط العرب. بليز جست فقط الاي دي هذا، لأن ما يعرف الأشخاص هو، فهذا موجود يعني يدخل، مع الاعتذار للجميع. نعم الله. وتبقى بس شغلة واحدة، يعني صراحة يعني أرجو أن تعذرون عن أي هفوة صارت وهي أكيد غير مقصودة. تحياتنا للجميع. شكرا دكتور دكتور.
عفوا بس صورة جماعية بلا زحمة عليكم لغرض التوثيق فقط.
يلا اخوان بدوزع مصورة جماعية على الستيج.